Okay, let's talk about the CT scans of the thorax. So quick overview. We're going to be talking about respiratory systems, so anatomy and pathology and protocols related to that, and then once we've covered that, we'll work our way into circulatory systems, so like coronary anatomy, circulation, and then pathology and protocols for that. All right. So, in terms of respiratory anatomy, we need to be familiar with the appearance of the trachea on our CT images, and also be able to identify the right and left main bronchus, and how those are going to show clearly on our images is that we will see kind of a rim of cartilage, a circle of cartilage around a black spot of low attenuation due to the air there. So hypodense. And then, of course, in the right lung, we're going to have 3 lobes. In the left lung, we have 2. And these various stems and branches of the bronchi and bronchioles. We'll be able to identify those as well on these images. So, looking a little bit more in depth in how vascularization works alongside those bronchioles, because each one of these branches of the bronchus are highly vascularized, or we'll be able to identify arteries and veins running parallel to them. But the blood being pumped out of the heart into the pulmonary artery. So this is the only artery in the body carrying deoxygenated blood to the lungs, where it will be reoxygenated and then pumped back into the heart through the pulmonary veins into the left atrium. So let's look. I just want us to appreciate all of these fine branchings of both the bronchus, the bronchioles, and these arteries and pulmonary veins. We'll be able to see those very clearly on the images, but it helps us to kind of have an overview of what we're looking for. So, in terms of the respiratory system, a lot of what we need to look for, we don't need to use contrast. So, because the thorax already has a high degree of subject contrast, so IV contrast is not necessarily needed to evaluate pulmonary vessels, ribs, or the lungs themselves. Nevertheless, the radiologist might request use of IV contrast to differentiate different vascular from non-vascular structures. So in particular, things like lymph nodes or suspected tumor, and especially to evaluate cardiac vascular structures. So a routine chest CT, we do quite a few of these. This protocol is a 64-slice protocol, and reasons for doing this procedure or this exam include infection, mass, empyema, lung nodules seen on a chest x-ray, and trauma. And then if we suspect cancer, we want to give oral contrast prior to scanning, just to help us differentiate between the esophagus and surrounding structures like lymph nodes. And also we want to make sure we scan through the adrenal glands. That's really, really critical, because that's a common route of spread. We're going to do a scout, AP and lateral. We're going to scan from above the apices through the adrenals. We'll ask the patient to take a deep breath in and hold it. And then we're going to have a digital field of view that includes the entire chest. If we're asked to use contrast, like on a trauma study, we can probably get away with about 80 milliliters of low osmolality contrast given at a rate of 3 milliliters per second with a delay of 35 seconds. And then technique-wise, let me move this slide around just a little bit. It didn't display quite right. But if we're looking at the technique, we're going to have a slice thickness and interval of 2.5 by 1.2 millimeters. We'll have a pitch of about 1, so just over 1, 1.3 1.375. That's going to be consistent throughout all of these protocols that we're looking at. KVP wise, we want something around 125, and then we can generally use auto MA on these, and we'll give it a max and a minimum. So the minimum might be around 100 through a max of maybe 150 for the new generation scanners. Okay, now CT chest for a lung nodule. Again, we'll do an APN lateral. We're going to scan from above the apices through the diaphragm. We'll have the patient take a full inspiration. We want to include the entire chest, but we don't need to use any contrast on these exams. Slice thickness is about 2.5 millimeters by 2. Pitch, again, the same, 1.375, KVP around 120, and then we can also use the auto MA with a minimum of 100 and max around 170. The main thing is we don't need to, if we're looking for a lung nodule, we don't necessarily need to give the patient contrast. So here's a CT chest, routine chest study, showing lung cancer, emphysema, and some cigarettes in the patient's shirt pocket. Let's move along to the heart. So it's helpful for us to kind of think three-dimensionally about all this vasculature prior to jumping into sectional images. But I think one of the main things I want us to look at here is both the actions of how the superior vena cava works. So we have the brachycephalic vein draining into the superior vena cava, entering the right atrium, entering the right ventricle through the tricuspid valve. It's then pumped out into the lungs through the pulmonary arteries. So this is the main pulmonary trunk, and then we can see the left pulmonary arteries here. One thing I want us to pay especially close attention to is right here, these three arteries up on top branching out from the arch of the aorta. We have the right brachycephalic artery, then we have the left common carotid artery, and then we have the left subclavian artery. The reason this is significant on the CT images, if you can imagine, this is the brachycephalic artery coming over. The right common carotid artery is going to come up off of the right brachycephalic, and then also the right subclavian artery is going to branch off from the brachycephalic. So then the left common carotid comes directly off the aorta, and then there is not a brachycephalic over here. There is just a left subclavian artery. So I want us to kind of orient ourselves in that area, be aware of how the vasculature works exiting the heart. So circulation-wise, we have blood entering perhaps through the superior vena cava or the inferior vena cava into the right atrium. It's pumped through the tricuspid valve into the right ventricle, and then it exits the heart through the pulmonary valve and out into the lungs through the pulmonary artery. It comes back into the heart through the pulmonary vein, enters the left atrium, and enters the left ventricle through the mitral valve, and then it exits the heart through the aortic valve and is pumped out through the body. The critical thing for us to remember here is that this is a circuit, that it and how this blood flows from place to place. And our book does a good job of kind of walking us through the flow of blood through the heart. Just trying to find, I believe it's on page 269 under circulation. So, pathology related to the circulatory system. We have coronary artery disease, or CAD. It's often treated with a CABG, or coronary artery bypass graft. And the kind of things that we might do to evaluate for that is the CTA of the heart, calcium scoring. CAD is the single leading killer of U.S. men and women, according to the American Heart Association. Another big important one for us in CT is a PE study. So we're looking for a pulmonary embolism. This would be similar. This is a significant test and is related somewhat to the VQ scan from Nuke Med. But PE, there's at least 100,000 cases of PE every year in the United States, and if it's untreated, it's associated with about a 30% death rate. And then, of course, congestive heart failure. We don't really have like a CT exam kind of geared towards that, but it was very easy to evaluate for CHF on CT images. So we won't actually address that in a particular protocol. Just routine chest CT would be able to evaluate that. All right, coronary artery disease is also known as ischemic heart disease. Has to do with atherosclerosis, so fat or cholesterol plaque being built up in the coronary arteries. And this buildup or blockage causes a partial or total blockage, and it prevents the heart muscles from receiving adequate blood supply. Again, this is the single leading killer of men and women in the United States, so it's an important thing for us to be able to diagnose clearly with medical imaging. So, in terms of protocols, this protocol is geared towards a 64 detector machine, and we're going to do an APN lateral in the first phase, and in that first phase we're going to scan from the clavicles to 2 centimeters below the apex of the heart without any contrast. We're going to ask the patient to take a complete inspiration. We're going to scan the entire chest, digital field of view wise, and then the technique is going to be about 2.5 by 1.25 millimeters, and the pitch right in that range of 1.375, and then a KVP/MA combo of about 170-150. Okay, and it can depend a little bit depending on patient size. So once we've completed the non-contrast phase, we're going to go to a contrasted study of the heart. So phase 2 of this, we're going to scan again from the clavicles to 2 centimeters below the apex of the heart on a complete inspiration, but we're going to make a smaller digital field of view. We just are interested in the heart. We are going to be using contrast, and we're going to be injecting it pretty quickly. So we're going to use about 8 milliliters of low osmolality contrast media, followed by a saline bolus, injected at a rate of about 5 milliliters per second. We're going to do a timing bolus, and then once we see the contrast perfusing in the circulatory system, we'll do about a 6-second delay, and then we'll initiate the scan. Let me move this slide. The technique, we want a pretty small slice thickness for this. So notice the difference in the slice thickness. We've dropped it down to half of a centimeter, so 0.625 millimeters by 0.625 millimeter. And the pitch is going to be gated, so it's going to be determined by the patient's heart rate. And our textbook goes into a great deal of detail about that, but nevertheless, just know that if necessary, we may need to give the patient beta blockers to slow their heart rate so that we can get images of the coronary arteries without too much motion on the pictures. So we're going to gate this scan, and we're going to pulse kind of according to how the ECG gating works. And then KVP and MA is about 120, and notice the rise in MA around 800. We need that higher MA to account for both the decrease in slice thickness and interval and also the contrast. So there's a nice pretty picture of a heart. We can visualize them in these three-dimensional images. This is probably done on Terra Recon Station. We can also do MIPT or multiplanar images of the heart, the individual coronary arteries. So it's just institution dependent what they actually want us to do with the data, and the radiologist should be able to guide you in those decisions. So another way that we can look at CAD in the heart is just do a CT cardiac calcium score. These are pretty quick and easy exams to do. Again, we're not going to need to use any contrast to do these images, so we're just going to get a scout. We're going to scan from below the carina through the apex. So we're scanning in a really small area. We're just kind of focusing just on the heart on these images. We're going to do an inspiration, and we're going to again cone down the digital field of view to just the area of the heart, and we're going to do slice thicknesses of about 2.5 millimeters by 2.5 millimeters. And again, it's going to be the pitch is going to be gated off of the center of the R peak, and we'll set the technique depending on patient's weight. And one thing that's significant about this, again, this protocol is for a 64 slice machine. Don't use the breast shields that can get in the way of how the automatic calcium scoring calculations are applied. And the purpose of this is to assess for risk of CAD in an asymptomatic patient, or a patient maybe with one or more risk factors for CAD, or to evaluate a patient with equivocal symptoms of CAD, or even to follow up like drug therapy for patients who have had CAD in the past. All right, and this is what these pictures kind of look like. The machine will actually take the data and feed it into a computer program that will then gauge how much calcium is in the various arteries of the heart, and it will give you a series of numbers. So it will report really accurately what the risks are for different p-values or leaks, and it's going to be looking at the different valves and cusps and arteries in the heart. All right, pulmonary embolism. So a thrombosis is just the development of a clot, and that's not necessarily a bad thing. Sometimes thrombosis can be a life-saving, especially if a patient experiences some kind of hemorrhaging. Nevertheless, thrombosis can be dangerous if it stops a blood supply to something important. An embolus is what we call like a thrombosis, a clot that's gone mobile. So a detached clot, it's detached from the place of formation, and now it's traveling through the bloodstream. It could be things other than a clot. It could be a fat embolus, air. We talked about air embolism with contrast injections from mechanical injectors, or a tumor could actually create embolisms, and that's part of how cancer can spread. Nevertheless, most PEs are caused by thrombi originating in the lower extremities, so like deep vein thrombosis. So we do really common for us to see ultrasounds for DVTs, and then follow it up with a PE study. So this CTA of the chest, a PE protocol. We're going to do an APN lateral scalp, and we're going to want to scan from below the diaphragm up through the apices. So we're kind of switched the game a little bit in that we're going to scan from inferior to superior, and this is so that we are able to adequately visualize the pulmonary arteries before the contrast has exited. Nevertheless, something to think about if we're going to do like a run-off type study. If we're not just interested in PEs, but we're interested in how the entire aorta perfuses, or like following the aorta down to evaluate for some kind of aneurysm or disease in the aorta, we would want at that time to scan from superior to inferior. But if we're looking for PE, a lot of protocols call for an inferior to superior scanning direction. The patient's going to hold their breath. One thing that's important with these studies is to not have to specifically tell the patient not to take a deep breath in and hold it. Just ask them to stop breathing. Because if they take a deep breath in and hold it for these PE studies, it can actually force the contrast out of the pulmonary arteries due to the way that the lungs function and the effects of the lungs on the flow of blood. So just stop breathing. A lot of times is what the machines are instructed to tell the patient. Our digital field of view will include the entire chest, so around 38. Contrast amounts can be pretty high. About 120 milliliters is pretty standard for low osmolality contrast, followed with a 50 milliliter saline flush. And the rate's going to be pretty high too, about 4 milliliters per second. And we're going to delay this based on the pulmonary artery. So we might set an ROI on the pulmonary artery, or just monitor the pulmonary artery, and once it has once we see a fairly high amount of contrast, like a peak of the bolus in the artery, then we'll trigger the machine to scan. So slice interval is going to be pretty thin for this, 1.25 millimeter by 0.625 millimeter. Sorry, and catch up with my notes here and write the rest of this in. Pitch again is going to be 1.375 for the pitch, and KVP is going to be about 120, and MA is going to be, we can do auto MA on this, but probably the peak MA we're going to want is going to be about 500, and again that has to do with how quickly we are scanning. And this is primarily used just to rule out pulmonary embolism. So here we have some pictures of what we would call like a saddle emboli. This is following immediately upon, so perhaps the tech has set an ROI on the area of the pulmonary artery, and it's triggered the scan, and now we've initiated some really nice pictures through the pulmonary arteries, and we're able to adequately visualize embolism, kind of a saddle embolism, so it's straddling the break, the fork in the road between the right and left pulmonary arteries, and then there's also a little embolus over here. One of the things that's really critical about this is that we have adequate contrast in the pulmonary arteries, so you can actually screw up a PE chest study pretty easily because it's a pretty narrow window. Perhaps this scan, I don't know if it was initiated pretty late. That'd be my guess that this is an incidental finding, because this looks more like these images look more like they're in like a non-equilibrium phase. I see some contrast in the inferior vena cava, but not very much contrast in the actual pulmonary arteries. So this may have been a routine study, perhaps to evaluate whatever's going on back here, and as an incidental finding they found embolisms in the pulmonary arteries here. Nevertheless, we want to be very careful about how we trigger these exams, that we place the ROIs appropriately. Sometimes due to patient motion, I've seen due to patient motion the ROI slipped and it landed on the sternum, and it triggered early because of the patient movement, and then we did not get adequate contrast because it triggered too soon. So we want to make sure that we place the ROI directly on the pulmonary, so this would be the pulmonary artery there, and that we are looking for a good amount of contrast being in those pulmonary arteries at the time of scanning. So that is. Thank you so much. This just incidentally, this is something I found kind of interesting for myself online. This is from the National Museum of Scotland, and they found a 17th century watch that was lost in a wreck of a ship called the Swan. That was a warship off the west coast of Scotland. This happened during the English Civil War, and the artifact was covered with barnacles, and they couldn't adequately discern what it was, so they did a 3D reconstruction of the watch. After doing some kind of tiny CT scan, it says at 63 micrometers, and it allows you to see all the inner workings of the watch, and it even made engravings on the case readable. All right, thank you.